Good morning to everybody. Today we have a very interesting case. Very young patient with several cardiac arrests. Apparently nothing of abnormal unless the presence of early repolarization at the EKG. I am working today with Professor Ciconte. Professor.
Hello, good morning, everyone. Welcome to this fourth episode, and thank you to Professor Pappone for hosting the case, and also to our guest. We have Professor Giovanni Forleo from Milan here as a chairman of this event. Hello, Giovanni. Thank you for joining us.
Thank you, Giuseppe. Thank you, Professor Pappone. It's a great privilege for me to follow this case from this position. Thank you.
Thank you very much, Giovanni. So everybody knows what is the early repolarization. I want just to summarize our experience in this field, because the early repolarization is one of the cardiogenetic disease. You know, Brugada syndrome, long QT, early repolarization. All of them, in the majority of the cases, are localized in the pericardial cavity. And as you know, from the beginning of our experience, we assessed the endocardium, but immediately we understood that most of these cardiogenetic diseases are localized in the pericardial cavity with a very specific substrate. So we initiated our work exploring this chamber. This is a section of myocardium, and clear you see that the smallest part of the myocardium is the pericardial cavity, confined by visceral pericardium and the parietal pericardium. You see, this is the typical mesothelial layer of the pericardial cavity, facing with the pericardial fluid. But what is important to say that these cells are not typical mesothelial cells, but can range in morphology from flat to cuboidal, adapting their activity to the environment. Important is the presence of microvilli. And this mesothelial population is very close to other immunogenetic cells, lymphocytes, fibroblasts, and monocytes. In particular, a lot of macrophages in this chamber. As you know, in the pericardial cavity, we have immune cells and a very high density of immune system function. We have myeloid cells, macrophages, dendritic cells, neutrophils, all of them driving inflammatory response. We have also lymphoid cells, in particular in the pericardial fluid, and not less important, the epicardial fat. In our opinion, the epicardial fat is responsible for the majority of inflammation, of the majority of mechanism of inflammation involved in the creation of the substrate of cardiogenic disease. You see the different level of activation of the epicardium in according to the immune response. We can have in healthy states, just resident immune cells, or inflammation states when we have the infiltration of immune cells, releasing cytokines, destruction of extracellular matrix, leading to the inflammation. And at the end, we have the disease, go back, we have the disease, the fibrosis. The fibrosis, in our opinion, is the substrate of long QT syndrome and early repolarization. And in very few cases, also the substrate of Brugada syndrome. And usually the chronic inflammation activates myofibroblasts, causing fibrosis and contributing to the arrhythmia mechanism. Don't forget, because in the future, most probably we have to take the attention on this fifth chamber of the heart, because this chamber is the main player of many mechanisms causing sudden death. Right? And this is just a representation of the molecules produced by these mesothelial cells and by these immune cells. You see, they produce a wide range of molecules influencing the inflammation, tissue remodeling, and fibrosis in the pericardium. All these cells, in combination with the immune cells, can create the substrate of sudden death. Right? And this is the typical mechanism of pro-inflammatory cytokines inducing significant structural remodeling into the heart. And this mechanism is not only responsible of the mechanism and substrate in cardiogenetic disease, but also in the majority of cardiomyopathy and ischemic heart disease. This is an example of the role of the epicardial fat. You see, initially the fat is on the epicardial space, and then it penetrates in the myocardium, creating the dishomogeneity and the abnormal conduction, and creating the substantial substrate for sudden death. Right? This is the typical representation. We also did in this patient the CT scan reconstruction with the visualization of the normal muscle on the anterior wall of right ventricle, the localization of the fat, and very important in the young patient, the identification of the anatomical localization of the coronary artery. So in every patient, we do the CT scan to exclude the presence of the coronary artery in the region of interest. Go ahead. We studied this population with cardiogenetic disease and the assessing of the omic from the DNA, RNA, and the proteomics. We found an overactivation of the immune system. Go ahead, Avanti. And we published also a paper demonstrating the role of immune system in worsening the genetical predisposition of Brugada syndrome, and the antibody are directed to the sodium channel. Go ahead. But this is not just for Brugada. We have the very similar mechanism in other conditions and in the majority of the arrhythmias, from ventricular arrhythmias to the supraventricular arrhythmias. Go ahead. And not only these antibodies are responsible for cardiogenetic disease and arrhythmias, but also for the progression of valve disease, the stabilization of conduction system, coronary artery activation and inflammation during the myocardial infarct, and at the end in the pericardium. You know, the macrophages play a very dominant role in the mechanism of the phenotypic expression of all these conditions. Go ahead. And what we found in the last 10 years is that we have three typical substrates, most probably produced by the genetic predisposition in combination with the immune mechanism in the pericardial cavity. You see, the substrate of long QT is associated with the presence of low voltage and fibrosis, showed in red color, and the normal tissue is in purple. Completely different is the substrate of Brugada. You see, the purple doesn't mean normal tissue, but is not low voltage tissue. And we found fibrosis very rarely, And in our opinion, the mechanism in the Brugada is completely different. And as we said, is due to the transient immune mechanism creating the presence of a pattern on the EKG and abnormal electrical activity on the outflow tract, anterior wall, or in inferior wall of the right ventricle. Very rarely in the left ventricle when we have the combination with early repolarization. And then we have the substrate of early repolarization. Very frequently, the abnormality are similar to the long QT, so we have reduction in the voltage and presence of fibrotic area, in particular in the outflow tract or very close to the tricuspid valve. Interesting is the localization of the fibrosis very close to the tricuspid valve. This is the reason why 25% of patients with Epstein disease have sudden death, and the fibrosis has been found during autopsy. Go ahead. And obviously, all this mechanism needs time to become pathogenetic. And we move from the little double potential to the fragmentation and fibrosis. So clearly, we have reduction of the voltage in the tissue until we arrive to the fibrosis that is the site for initiation of ventricular fibrillation. So what about the early repolarization, Giuseppe? You see, early repolarization is the case today. We have a very high prevalence of these EKG abnormalities, but one of the big problems when the early repolarization is really disease or is just an aspecific representation of the EKG. For sure, when the patient has had cardiac arrest, it became interesting to explore because the early repolarization in combination with the clinical experience of cardiac arrest obliged to investigate in this direction. And in according to our experience, also in this patient, we are going to explore the substrate in the pericardial cavity. He did already the electrophysiological study showing that there are no abnormalities in the conduction system in the East Purkinje, and was not inducible any ventricular fibrillation during the EP study, right? You know, we have different type of early repolarization, and typically on the right you have the most severe type of early repolarization, the malignant one, but the case we are dealing today is not a very malignant early repolarization, and although without malignant early repolarization, this patient had 3 or 4 episodes of ventricular fibrillation. In the first episode, he had cardiac arrest, resuscitated and implanted. And very recently, in the last 3 months, he had 3 consecutive episodes of ventricular fibrillation, well documented in the ICD monitoring. Interesting, you will see, all the ventricular fibrillation were not triggered by PVC. So most probably the substrate is the dominant mechanism in this case. Go ahead. Okay, go ahead. This is an example of a patient we already treated. Go ahead. This is the documentation of ventricular fibrillation. It's not the patient today. You see the endocardium is very normal, but typically the tricuspid valve is very damaged with the presence of fibrosis. Go ahead. And our approach is the mapping and the documentation of double potentials and low voltage signals. So our type of map is a voltage map. Go ahead. You see double potential, right? Completely abnormal compared with the normal tissue visualized in purple, right? And the approach is the homogenization of the area involved in the reduction of voltage and fibrosis. And interesting, in our previous cases, the patient stopped to have ventricular fibrillation just ablating this area. And this is after the ablation, go, right? And you see after the ablation, no more double potential, right? Right? And interesting after, vai quella prima. Interesting, after the ablation, we have the breakdown of the early repolarization. This is a very interesting behavior after the ablation, indicating that the early repolarization is strongly correspondent to the amount of fibrosis and is the phenotypic expression of the fibrosis, right? Okay, you know, 30% of patients may have overlap with Brugada syndrome. This is a case of a typical pattern in V1, V2, and V3 associated with early repolarization in lead 1 and AVL. This is a Philippine patient. Go ahead. Vai. Okay, you see on the anterior wall, we have the typical substrate of Brugada. But interesting, we have the localization of Brugada in the inferolateral aspect of right ventricle and the left ventricle. Right? You see in the left ventricle, we have the Brugada substrate, right? And after the ablation, we have the normalization of the electrogram, right? The reduction of early repolarization, the disappearance of Brugada pattern, right. You see the disappearance of Brugada pattern, no more early repolarization. And we can introduce this case saying that every cardiogenetic disease has a substrate. Brugada syndrome, a typical dynamic substrate associated with a normal voltage substrate. The early repolarization, low QT, very similar substrate associated with fibrosis. Go ahead. So every cardiogenetic disease has a typical signature. We can have the prolongation of abnormal electrical activity in the Brugada, and in the early repolarization, long QT, double potential and fragmentation, and in the right ventricular or biventricular dysplasia, the important reduction in the voltage. So Giuseppe, let's go to the case we are going today.
Slide presentation, please.
Maybe she
Okay,
knows.
after this main lecture, Professor Pappone, you have been introduced to not only early repolarization, but also arrhythmogenic disease and arrhythmogenic substrate in cardiogenetic disorders. Next slide, please. We are dealing today with a very young patient. He's a 24 years old male. He had a family history of sudden cardiac death, and this is something that is always overlooked in many patients because it is the main factor leading and providing and seeking medical attention, especially in young people. In 2023, he was a lucky survivor. He had a cardiac arrest, was successfully resuscitated, and after that, he underwent a dual chamber ICD placing. Interestingly, at the MRI analysis before the implantation, there was no LG abnormalities. However, cardiac dextroposition is an oxydextrocardic patient, but a dextroposition, and you will see in the fluoroscopy, which might create some challenges in the epicardial approach, and we will show you later the epicardial puncture. But most importantly, we didn't observe any abnormalities into the MRI of the right and the left ventricle as well. Of interest here, we can see the ECG. And the ECG, although you might see, due to his bradycardia, the pacing into the right atrium, but you can clearly appreciate in the inferior leads an early repolarization pattern. Here you see a pseudo delta wave in the late part, in the terminal part of the QRS, typically indicating let's say late depolarization pattern, which is not the form, the malignant form Professor Pappone has shown. However, by giving back you a big picture, he survived the cardiac arrest, and this is the ECG that we face. So clearly an early repolarization pattern with a malignant form in a phenotype expression of the disease. Next slide, please. As Professor Pappone said, we faced him after 3 shocks. So cardiac arrest, resuscitated, the first index event, implantation of the ICD, and then 3 shocks. Next slide. This is the first one. Again, you don't appreciate a clear PVC triggering the event, so immediately a polymorphic ventricular tachycardia leading to VF, successfully terminated by the ICD. And this was the first shock in October 2024. Next slide. Again, this is the other case in November. Next slide. And finally, the other case end of November 2024. So again, we are dealing with 3 episodes of spontaneous ventricular fibrillation not preceded by PVC triggering this activity. So we can go to the EP room now. Alessandro, go to the Odyssey. Stop the presentation, please. And we can show you the mapping that we have performed today.
We did the CT scan. In this case, it's extremely important because the patient has dextrocardia. So we need to localize very well the localization of the right ventricle, where is the left ventricle, and even more important, the anatomical correlation with the coronary artery. Very clearly, you can see the right ventricle. Behind the right ventricle, let's see the left ventricle, Beniamino, okay? And you see the coronary artery is well localized only on the left. This is the interventricular artery. Go to the right, please. And you see the right coronary artery determining the border between right ventricle and right atrium and left ventricle. So we already went into the pericardial cavity.
You want to show the endocardial first?
Yeah, you want to show the endocardium. This is the endocardium. The catheter is placed already in the pericardial cavity. And we are using the same optrail catheter, high density mapping catheter. It's a very special catheter to visualize a very small amount of the tissue and to explore the epicardial environment and the tissue in particular. And the voltage map is extremely precise, and the number of points we can acquire is extremely high. So what is our endpoint? To explore the quality of the ventricular tissue in the epicardial cavity and to drag the catheter very smoothly. And you see, I am in the hot foot rat. We are at the border of pulmonary artery.
Can you focus on the carto, please?
Can you focus on the carto? You see the potentials?
Okay.
In this region, we have little fragmented potential, but not abnormal. Let's see first in another region to see.
As you can
okay, this is the normal activity we have in the right ventricle. We have a very smooth, very teeny line, no double potential and no fragmentation. This is healthy tissue. We consider this tissue extremely normal, and we are depicting this part of the right ventricle in purple because it's completely normal. Okay,
Here
now
we are moving towards
I
the
am
outflow
moving
tract.
towards other region. Oh, here we have a very clear region of low voltage activity. You see? We have fragmentation here. What do you think, Giuseppe? But we are at the border of right atrium
right,
here.
right.
So I am pulling back the catheter, reducing the mapping of right atrium. But at the border, you see, we have not smooth and teeny line. We have fragmented and with lower voltage. Let me go in upstairs.
Ben, can you go 400 millisecond speed, please?
So, Professor,
Oh,
looking at
guarda, sia, sia. Oh, we have the double potential. Here the tissue is completely abnormal. What do you think, Giovanni? See?
looking at the ECG, where do you find where do you think we will find abnormal signals? In which part of the heart? Is there any correlation with the ECG?
The correlation is not very strong, but in V5, V6, and V2, V3, and V5 are probably the EKG expression of this region. You see, you expect usually to have in the inferior part of right ventricle, but clearly we have low voltage and fragmentation at the border of pulmonary artery, see?
Now we are showing the ECG. You can see the live screen ECG that you have an inferolateral early pattern clearly demonstrated in V3 to V6 and in the inferior leads. As Professor Pappone said, we don't have clear expectation on the inferior part of the
See, here
heart.
we have fibrosis.
But
Benjamin,
if you go back in
we
the
have
carto,
fibrosis here, huge fibrosis and the double potentials. Here,
look at this.
look at this. Here,
This
we
is
have normal, 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 abnormal, abnormal, abnormal.
Here you see.
So here is the border between the disease and normal tissue. See? So most probably the cardiac arrest is coming from this region. See? And this is very typical also in the long QT syndrome, Giuseppe. You remember
Yeah.
last
showed
cases
last
we
case.
did was associated with this double potential, fragmented potential, and
Yeah.
low voltage.
Here you can appreciate.
You
better.
can appreciate the fibrosis here, see? How you titrate the voltage, Beniamino?
Yeah, between 0.4 and 0.8, because we are using a little lower value compared to the endocardium, but this is the standard voltage that we use in
This is an
epicardium.
unbelievable technology to map this type of arrhythmias. You can detect with these 32 electrodes, everything is detectable. Everything, see, is very clear. See here, it's
These are
unbelievable fragmentation and abnormal substrate. So the only way to predict the risk of this patient is the identification of this region. Unfortunately, the EKG not always correspond to the site of the substrate. See? Okay. Let's go to the left ventricle a little bit.
And Professor, due to
Yeah.
dynamic changes,
Alzategli un po' la voce perché non sento. Ok?
Professor, due to the dynamic changes of the J waves, do you think we can also find differences in mapping depending on how in that moment J wave are so prominent?
Yeah, for sure we have in the early repolarization the disturbances of depolarization. Officially, it has been considered in the past a repolarization disease. But if we see the substrate is not understandable as a condition of repolarization, but is a condition of depolarization, because the impulse propagation in this fragmented area cannot be normal. And this may explain the evidence of immediate degeneration in ventricular fibrillation without PVC in this case. Huh?
Yeah, absolutely. Giovanni, also you can appreciate that when the catheter is located in the region with a late activity upwards close to the RVOT, when we had this huge fractionation, which is late, and the late component is almost coincident with the J wave. So what we call J wave as the notching that is more appreciated here in D2 and D1.
See
And
the left
this is
ventricle is
is
normal.
a clear late activity. This late activity is let's so-called late depolarization more than, as we said, early repolarization. So again, this is pointing towards a disease which is more related to the depolarization abnormality rather than...
In the left ventricle, the activity is completely normal. Huh?
Yeah, we don't see late activity, fractionation, so again, the signal is
And
is
we are
absolutely
close
normal.
to the descending artery.
Let's over-
Ruota un po'.
molto indietro,
Mm?
molto indietro. no?
Sì, sì, lo so. So interesting to have the localization of the coronary artery to avoid the risk of ablation of
And here is
coronary
completely
artery.
normal. You see.
Here is completely normal tissue. Let's see.
So it's not all the right ventricle involved into the disease. It may vary among the patient, right? Professor Pappone has shown that some cases with a severe pattern of early repolarization pattern and cardiac arrest, they have involvement of the peritricuspid area, but also you can see that you have late activity. If you look in the carto, you have a near field close to the ventricle and then a late activity. These double potentials are not normal. And again, if you compare with...
Beniamino,
yeah, you can...
can I see
here.
the gross anatomy of the pericardial fat we detected at the CT? Facci vedere l'immagine del grasso, quella che mi hai fatto vedere prima. Ce l'ho, ce l'ho.
Prof, riusciamo solo a vedere qui la zona, un attimo che tolgo proprio la mappa dell'EPI.
Sì, togli la mappa dell'EPI e facci vedere il grasso e poi la rimetti.
Ok.
Quella proprio ecco qua, sì? This is the fat localized
In AV
just
groove.
on the pericardial cavity. And our opinion that all the story starts from this fat localization, because the
inflammation.
resident cells are there.
The
And
inflammation.
we have the inflammation starting from the fat and move very close to the normal tissue. So closer is the fat, higher is the risk of having a substrate. So in our opinion, the trigger of this substrate is the pericardial fat. And in the future, we should talk about this new substrate. Most probably will be of interest in our interventional procedure. But in the near future, we prepare for you a procedure for the fact. Okay, so Giuseppe, I think it's the time to do the homogenization of the substrate and to move to the ablation.
Yeah.
What do you think?
Absolutely. I think
What
that
is the ablation we are going to do, Giuseppe?
we have clear definition of the substrate. Beniamino, rotate a little bit the map. You can clearly see that the area which is not shown in purple, we had this extremely late activity, very fragmented components compared to the remaining area of the substrate. So in other words, we are going to homogenize this area with an ablation with a dragging approach, 47 to 50 watts in a temperature control area.
Spingiamo un po'.
Un po' più avanti. Perfetto. Ancora. Okay, so we remove the optical catheter and we will use now the Q dot.
Beniamino, can you define the area with
Giuseppe.
a white line and the border with the right atrium?
Giuseppe,
Yes.
Yeah.
we have many questions from the audience, mainly focused on what are the criteria for catheter ablation in ER patients, and if there are other alternatives.
So, of course, this is a severe patient with a severe history of cardiac arrest and frequent ICD shocks. So, considering the evidence of arrhythmogenic substrate and the localization of the arrhythmogenic substrate in this scenario, so we expected to find abnormalities in this case, and this is our target for ablation. Of course, the indication is mainly led to the ablation. It is driven by the history of the patient, history of cardiac arrest, and frequent ICD shock. Of course, in the future, we expect that the epicardial approach will be even broader.
Can you tell?
So, in the moment we are sitting in the area of the substrate, you see the signals in the Q-dot catheter. You see the fractionation. You can appreciate in the distal and in the proximal the fractionation in the signals. So we are performing the ablation, which will cover the entire area of the fractionated signals. Here again, as you can see, the pre-mapping is extremely important in planning your procedure because you are dealing with the substrate. It is on the anterior side of the epicardium, and most importantly, we are far away from the coronary arteries, so preventing any potential damage and any abnormalities and you can face during the procedure. So we are in the right spot. We are providing and delivering radiofrequency in order to get an homogenization of the substrate and eliminating all the late activity. Giovanni, you had other questions, right?
Yes, we have other questions from the audience, mainly now related to which are the target for ablation and what are the differences between ER and Brugada syndrome patients.
Sure. Here you saw the fractionation, which can be observed in some Brugada patients, but not in the same entity and the same amount. Brugada typically has a dynamic condition, as Professor Pappone said already. Most of the patients have a normal tissue, a normal amplitude with late activity, which is dynamic. This dynamicity is shown during a sodium channel blocker test, and only a minority of them may show lower voltage, but always this late activity, which is very delayed with a total duration of the signal, which is even beyond the 200 milliseconds. This is a completely different scenario. Here you have, most importantly, lower voltage, lower than 0.5 millivolts, as you can see by that bipolar map as we have shown. The fractionation is tiny, fractionated signals, not that prolonged as the Brugada pattern, and not reaching more than 150 milliseconds in the worst case scenario, but this fractionation is characterized by low voltage, frequent multi-peaks component, which is most importantly, you have always to compare with the other areas of the ventricle. In fact, if you go in the anterior wall, you see nice tall signals which are completely different with what we are targeting here. Professor Pappone now is moving into the spot of the target, into the area of
Fagli
the
vedere che non
substrate,
siamo sulle coronarie lì. Fai-
in the substrate
proietta.
here. And you can, by moving, rotating the structures, you see clearly that we are in the anterior side and far away from other coronary arteries. How much is important you consider, Professor, the contact in this case?
Is extremely important, the contact. Extremely important. And also important is the energy
Andrea.
we use.
Andrea.
We use more energy than typically is necessary in the endocardium. And the duration of each application is not more than 10 seconds. We want to be very superficial because the thickness of this disease is very teeny.
By the way, can you show in the meantime while we are ablating the ECG? Because there is something interesting that we can show you. Go ahead with ablation, no worries. ECG, Alessandro. Guardi le inferiori. So if you can compare the inferior pattern in the inferolateral, we have already something interesting. We don't have the same pseudo-delta wave, pseudo-delta obviously, in the late part of the QRS, and we have a little change in the ECG already. So again, the target that we are ablating in this moment, the spot that we have target now is changing the ECG, is affecting the ECG manifestation of the disease.
And we confirm that early repolarization is a regional disease.
Yeah.
We confirm Brugada is a regional disease. And the long QT also. And
So,
the EKG normally is
Alessandro Carpi.
a strong predictor of the localization. In the early repolarization, sometimes the EKG phenotypes does not correspond to the anatomical localization on the pericardial cavity.
Okay.
Can you analyze, Giovanni, the EKG? Can you comment the EKG? We have a little ST depression in lead 2, lead 3, and AVF. And
Yes.
clearly different from the beginning, see?
Solo l'ECG. Giovanni, we have focused now on the ECG,
Okay.
and we can clearly see if we compare before and after, you have before at the beginning of the procedure on the left side, and now the live screen on the right side, you see that we had a kind of depression of the ST elevation that was more evident in the inferolateral leads, and now looks like more flat and more flat towards the isoelectric line.
No,
Do you-
in this moment, the EKG is normal. No more early repolarization. You see the lead 2, lead 3, and AVF, no more early repolarization.
Is it common to find ST elevation during radiofrequency delivery? Such
Today
as
we are
Brugada
lucky.
syndrome?
Today we are lucky because we are in live.
but typically you can appreciate those ST elevation only in V1 and V2 when you place the precordial leads in the second or third intercostal space, which are the higher precordial leads placement typically for Brugada. But in this case, obviously, this is the normal setting. We are not
Yeah.
dealing with a Brugada patient, so no reason for
Can
looking
you
for that.
emphasize with the video camera the EKG and amplify the EKG, because I don't see anymore the early repolarization. No
Sì, sì, lo sta facendo.
pre-excitation. Can you amplify? Amplifica un po', Alessandro.
Non lo riesce a fare. Lo riesce a
Amplifica l'ECG.
We have one more question about any potential role of endocardial ablation in this subset of patients.
Yeah, you know, we explored this possibility in the past. We started our project on the cardiogenetic disease in 2012, and I remember the debate in the congresses when Michel Isaguer and Adamani were really convinced that the substrate were localized in the endocardium. And they wrote several editorial reporting that in their opinion the substrate was in the endocardium. And a lot of people started to address this cardiogenetic disease from the endocardium. I think today nobody continue to think in this way, and we have a lot of the demonstration that for many reasons the substrate is in the pericardial cavity. The endocardium in this patient is completely normal, for example. The totality of the patient with Brugada syndrome have completely normal endocardium, and the same for long QT. So today nobody can say that the substrate of this condition is endocardial substrate.
And do you think that genetic test could be important in stratifying these patients?
The best way to stratify this patient, Giovanni, is the family history. The family history of sudden death in combination with early repolarization at EKG is of interest. Another important manifestation is the syncope without arrhythmias. Very typical, the patient with early repolarization at high risk has several syncopes before the cardiac arrest. Most probably because the extension of the area is quite big to create an electromechanical dissociation, regional electromechanical dissociation, and hypotension. Usually the syncopes in this patient are without ventricular arrhythmias.
And what about the left or right ventricular function after the ablation? Can it be compromised?
In the long
some way?
QT, the left ventricular function improves because we reduce the prolongation of QT, and the consequence is the normalization of the diastolic and systolic function. In this case, we do not expect any improvement because the heart of this patient in terms of hemodynamics is completely normal. But Giovanni, I think this case is extremely important for the history of the electrophysiology. This is a live demonstration that the cardiac arrest in this patient is associated with the early repolarization detectable at the EKG, not the worst early repolarization. The substrate is localized in the epicardium, and the ablation of the substrate is associated with the normalization of the EKG. Everything is live.
We have one more question. Is, in your opinion, more easier to ablate Brugada or ER patients?
No, capito?
It's more easy to ablate a Brugada or
ER patient with early repolarization syndrome?
an early rep.
It's the same. Important is to learn how to get the access in the pericardial cavity. use the right technology for the mapping, to be very accurate in the evaluation of the signal, and to train yourself in navigating and ablating, not to be in a hurry, because a small mistake can cause a huge consequence. And do not ablate too much. I think we ablated enough.
Yeah.
And I am very satisfied. Stop.
And
Important
another thing-
is EKG is completely normal now. No more early repolarization.
HCG, focus on the ECG.
Focus on the EKG.
Another point, Giovanni, that I think must be said, a huge difference between this procedure and the Brugada procedure is the use of the sodium channel blocker. You have to be cautious in administrating the ajmalin, cautious in evaluating the side effects of ajmalin, because in this case, sometimes, most of the cases is safe. They are safe administration. However, there could be some... irrighiamo, l'optrel, irrighiamo. Uno, vai, a uno. Vai.
So Giuseppe, you don't recommend to use ajmalin in these patients?
Well, it can be used, but only to exclude a Brugada pattern overlap. In this case, there was no evidence of that.
We did the ajmalin test in the risk stratification of this patient, and the ajmalin test was negative. If you want, we can do now, no problem.
But normally is not necessary for the sake of the procedure. So this is...
But we can do, Giuseppe.
Yeah, I mean, it's not in this procedure to perform ablation of early repolarization. Ajmalin is not necessary. However, it is necessary in the diagnostic phase, because a patient like this may hide a Brugada syndrome as well. So it is important to exclude this compresence.
But I think we can do today.
Yeah,
no
yeah,
problem.
we can do at the end of the procedure, after having dealt with the arrhythmogenic substrate, we can do ajmalin test even to show the results of it and to show that there is no overlapping condition.
But we know the patient is not Brugada because we prepared this case during the ajmalin test. Unfortunately, we did not prepare the slide, but we are.
Yeah.
Gira
we
di
can show.
Benamino.
So clearly here we
So,
don't have any more the
more fragmentation, see? No fractionation, see? See? Very smooth, see? Ok, Giuseppe.
Si muove? Introduttore più avanti, introduttore più avanti.
Ok, lascia, lascia.
Ok. Posteriore?
Penso di sì.
Ok, adesso anteriore. Adesso anteriore. Ok. So we are in the middle of the area. Actually, far away now. Posteriore, posteriore. We are posterior oriented. Now we need to move anterior. That's left. Posteriore, perché posteriore?
Prendi qua i punti.
So we are on the left more?
Left.
Ruoti con l'introduttore.
Eh?
L'introduttore. Usi l'introduttore. Good. Now? Now we are on the right. Okay.
Vai. Lascia.
So open a little bit. There. Now they are smooth. We don't have the similar
No
fractionation.
fragmentation. No fractionation.
Nice here. Look at this. So
The
we
sub-
don't have the fractionation as the beginning. You remember the signals there? Maybe Beniamino, you can show upwards. Yeah. The initial signals before ablation.
The signals before ablation here.
Before.
Yes.
No, vai ad adesso, dai, che non mi piace.
And you see the difference.
Facci vedere adesso.
This
No,
is
no,
real
really
time.
bad.
This is before ablation. I can put it here. This is before ablation. This is real time.
Yeah.
So we have
So we lost
double
the late
components.
component. We clearly lost the late component. So we have homogenized the substrate. We don't have
Dai, prendi gli ultimi punti che abbiamo finito.
any
dai.
more. And this is the demonstration that we could homogenize the substrate by radiofrequency ablation. If we look the ECG also, we don't have we don't have any more the early repolarization pattern as the beginning. Clearly, the inferior leads now look nice and nicely downwards. So we don't have any more the ST elevation that we had at the beginning. So although you see, Giovanni, we were discussing about inferior leads, abnormalities, and where could be maybe in the inferior part or the others, actually, the abnormalities were in the right ventricle, and
Finito, Beniamino, dai.
we have
Okay.
now
Tutto rosso, dai.
homogenized here the substrate, and the ECG has clearly and dramatically changed.
Indeed, we have a question about what ECG leads show the most evident changes after ER ablation.
That all of the previous ECG abnormalities that we had in the infralateral, now they are not showing anymore the early repolarization pattern. Actually, if you look D2 and D3, if you focus on the ECG, Alessandro, and outside you can show with the mouse, with the arrow, you can indicate the inferior leads, D2, D3, and V6, and you see that D2, D3, and V6 now, they don't have anymore this kind of slurring, late slurring, and
Completely
ST
normal
elevation.
electrogram. See, it's epicardial electrogram, completely normal. Vedi, Giovanni?
Yes, I see well.
Okay. I think we can be satisfied. We do the Eichmann test. Vai.
Another question is about what are the common locations of targets when ablating the ER patients?
The camera rotation.
The common location of the target.
Tricuspid valve. Tricuspid valve and outflow tract. Today is outflow tract, but very frequently the tricuspid valve is also a frequent localization. I tell you, in this case, I expected the localization in the tricuspid valve, looking at the EKG, but indeed we found in the outflow tract.
Ci date il timer, per favore? Timer, so we are going to start the Eichmann
Quanto ne hai
test.
caricata? Can I have water?
No,
On my
il
side.
timer in basso. Timer
Water
in
for
basso.
myself, not for the patients.
Sinistra, qua, ok. Aspetta. Dillo a lui di staccare.
Okay. Look the electrogram, look the EKG. We started the infusion of Ishmalin. We already did 15 milligrams.
No, focus on the ECG only.
Focus on the EKG. Okay. Okay.
So we are giving 10 milligrams right now. We have V1,
at 20
V2 in the second, third, and fourth intercostal space. We have moved the ECG, the high right precordial leads, just to appreciate
30 milligrams,
the outflow
Giuseppe.
tract.
Sì, lo so.
Actually, no differences.
Still on the way, but
No repolarization.
typically a severe case like this would have shown already huge abnormalities in V1 and V2, and clearly you don't see anything here.
Any abnormality, any prolongation,
20,
any fragmentation.
20 ora.
Siamo a 40, Giuseppe. We are close to 3 minutes. We gave 2/3 of the dose. In the general anesthesia, it's not necessary to give 1 milligram per kilogram because the effect of the Ishmalin during general anesthesia is much more powerful. We are at the end of the dose,
Almost there.
45 milligram.
Yeah.
I think it's enough. No prolongation, no abnormalities. The catheter is still there in the outflow tract.
No late activity.
No late activity.
So again, no sign,
pattern,
no
nothing.
sign of Brugada syndrome.
I think we can be very satisfied.
And do you
Stop.
think there is a possible role of AP study in this case?
Typically, in early repolarization, no. We didn't observe a real correlation with inducibility and phenotype, severity of the disease.
When we did the diagnostic study in this patient, there was not inducible any ventricular fibrillation.
And he had the spontaneous events.
Yeah,
So
and he had the spontaneous events.
we don't rely that much in early repolarization as well as we do in Brugada. But again,
So we normalized the local electrogram. We normalized the EKG. I think the procedure is very successful. Thank you very much for the attention. Thank you, Giovanni.
Thank you,
Thank you,
Professor.
Giovanni,
Very nice
and,
case.
Ciao.
Thank you.
to everyone.
Thank you, everybody.
Thank you. So before leaving you with the early repolarization case, ablation case we have performed to date, we want to share some insights regarding early repolarization syndrome. Following the procedure we have performed regarding early repolarization, we give some insights, general insights regarding this condition. Of course, early repolarization syndrome cluster has a variety of conditions because when we talk about a pattern which is observed in the 12-lead ECG, we have a high prevalence in the general population. However, if we think about the syndromic pattern or the pattern which is really associated with sudden death, we know that 40% of early repolarization patients, they develop VF and they have recurrences, and 27% of them, they experience multiple VF events. So the concept is this always a benign condition? Of course not. The ECG pattern clearly identifies those abnormalities which are mainly associated with a malignant early repolarization pattern, which is observed clearly in this slide on the right side, with the particularly pronounced notching pattern with a delayed component at the end of the QRS, which is observed in the inferior leads on the inferolateral leads, whereas a non-life-threatening, a more benign pattern is mainly observed here in the inferior aspect and in the lateral aspect with very distinct pattern compared to the malignant one. And again, those abnormalities, like a pseudo-delta wave on the contrary, on the upside down of the ECG, you observed in the most severe pattern, in the most severe conditions. These patterns have been already described and associated with life-threatening events in patients. In fact, in these studies in New England and JACC, they demonstrated this pattern associated with the events. And most importantly, the type of pattern which is rapidly ascending elevation of the J point in the inferolateral leads is clearly associated with a benign condition, whereas this is the malignant form we are searching for and when we observed a pattern like this, obviously it is associated with abnormalities. Obviously, these conditions are associated, of course, with a malignant prognosis. And of course, we know that the patient with a cardiac arrest or survived to cardiac arrest and with a positive family history of sudden death and the presence of this kind of pattern, obviously, this is the most relevant condition and the one that we need to be to care of. However, those patterns are not only the most limited ones. We could have a transient augmentation of the J wave, short coupling PVCs associated with this ECG, and with the high amplitude of the J wave and widespread J waves across the lateral leads or global leads in the anterior wall. Generally, we know that symptoms are driving the clinical decisions, whether or not implanting an ICD as primary or secondary prevention according to the symptoms that occurred. But poor evidence is yet for the catheter ablation. Here, considering the case we have treated today, and also I show you other cases we have performed in mapping and ablating J-wave syndromes or early repolarization syndrome patient. This is a patient of 33 years old with a family history of sudden death and appropriate ICD shocks due to VF in 2022. And at that time, 2 years ago, we admitted this patient to map his epicardium and highlight the presence or to investigate whether those abnormalities in the ECG lead were accompanied by epicardial abnormalities. This is the study at the time of mapping, and you see that also EP study and programmed electrical stimulation was associated with VF inducibility promptly treated by the DC shock. At the time of the mapping, the endocardial voltage of the right ventricle was fairly normal, whereas the epicardium of the same area was associated with huge electrical abnormalities, which are delineated by these white lines encompassing all these abnormalities. And all these areas in the epicardial area, which is the outflow tract and the anterior wall of the right ventricle, are characterized and clustering those late abnormal electrical activity with fractionation and low voltage amplitude. These are typically observed in patients with this kind of J-wave syndromes. And if we compare the left ventricular aspect is characterized by high amplitude, highlighted in purple, and absence of late activity, which is clearly the case in the absence of abnormalities. Those abnormalities typically are represented by late activity, fragmented components, multiple peaks and fragmented components, which are the target of our ablation. And in fact, by ablating this area and homogenizing the substrate, which is the goal, the ultimate goal of this ablation procedure, we get rid of this epicardial activity and ECG abnormalities. Of course, here we are facing with a new scenario of abnormalities. When we have ECG phenotype abnormalities, we have J-wave, Brugada, long QT, and they share similar clustering abnormalities, clustering in the epicardial region, whereas the absence of ECG phenotype is still uncovering a huge area, a huge spectrum of disease. And for this reason, we are in studying these cardiogenetic disorders, and we are every day more and more convinced about the fact that all of these conditions, they share similarities, and the most important similarity is the resident of the presence of abnormalities into the epicardial structure. And in the future, we strongly believe that will be reclassified as epicardial cardiomyopathies. And thank you very much for your attention.